Okay, guys, this is the perioperative lecture, which is chapter 39 in your F.A. Davis book. These are the key terms that you can find throughout your book or in your tablers, and these will be helpful for you to understand. These are the learning objectives, again, that are in front of the F.A. Davis chapter. So when we talk about perioperative nursing, this is the operating room. That's the old term. It involves care for the patient before surgery, during surgery, and after surgery. Historically, that perioperative nursing was called the operating room nurse and was limited to just transferring the patients in and out of the operating room and handing instruments to surgeons during surgical procedures. Now nurses in all phases of the operative experience provide care, teach our patients, and study the perioperative patients. The Association of Perioperative Registered Nurses is one of the most highly organized and influential specialty organizations within the nursing profession. They have standards and recommendations of practice. And if this is a line of work that you would like to go into, you could sit for a national certification through them, and that would display your competency in this type of nursing. Our perioperative focus is very much on safety. So we have to make sure that we do appropriate hand hygiene. We know that this is an important component of preventing the spread of infection. Our preventative perioperative errors cause 10% of surgery-related deaths. They have unfavorable financial impact on healthcare institutions and result in physical and emotional harm to our patients. So that's why safety is very important. When we look at preventable errors, these could be errors that we performed the wrong surgery on the wrong patient or the wrong site. And we have a lot of governing bodies that kind of oversee to make sure that we're doing the right thing. You have that Association of Perioperative Registered Nurses. Then we have the Joint Commission that has our standards and our safety practices. We have the National Quality Partnership, and this is an established national priority that includes and aims of achieving better care, providing improved health for people and communities, and making quality care more affordable. So one of its priorities and goals is making care safer by identifying the social detriments of health as means of providing health equality in the delivery of care. And then the last one that I have listed here is the Institute of Health Care Improvement. And this is an independent, not-for-profit organization that works to reduce morbidity and death in American healthcare. And this includes perioperative care. One goal of both is for the 100,000 Lives campaign, and its 5 million lives campaign was reduced surgical complications and specifically surgically infections. And there's a whole website that you can look at all that if you're interested. And then we need to talk about never events. So never events are serious, costly errors resulting in severe consequences for the patient that are mostly preventable. So what falls into the category of never events would be surgery on the wrong body part, surgery on the wrong patient, wrong surgery on a patient, deep vein thrombosis or pulmonary embolisms, specifically after if they have a knee or hip, any foreign body that can be left in a patient. So if they left a sponge or a clip, or I've seen the introducer wires get left in patients, and then surgical site infections. And we talked about that in our last unit when we were speaking more about promoting asepsis and how our surgical site infections would be a nosocomial or hospital-acquired infections. So we do not want to give our patients those, of course. So when we talk about surgery, we have our 3 phases in the perioperative world. And the first is the preoperative phase. This is the first phase. Depending on the patient's health status, this can last for a very long time to a very short time. So as soon as we decide that we're going to have surgery, that is the beginning of the perioperative phase. So if you think about a patient who's on a transplant list, they're in a very long preoperative phase. Or if somebody comes in with an open fracture of a joint, they might be going to surgery, within minutes of arrival to the emergency room. And then we have our intraoperative phase. So this phase begins when the patient enters the operating room. During this phase, the patient is anesthetized and monitored, prepped, draped, and the procedure itself is performed. They have to make sure that they do a timeout, which we'll discuss in a little bit. And then once it is complete, surgery is finished, we enter our postoperative phase. So the postoperative phase is the third phase and the last phase. It begins when the patient is admitted to the PACU and ends when the patient has completely recovered from the surgical procedure. Recovery from the surgical procedure may take several months because we have to do our wound healing and all of that stuff. To ensure a smooth transition from PACU, the nurse anesthetist or any anesthesia provider and a circulating nurse typically will give report to the PACU nurse. The Joint Commission recommends using handoff communication, which takes place between the intraoperative nurse and the postoperative nurse. So whoever was with that patient in the OR should be giving report to the nurse who will be caring for them outside of the OR. So how do we classify our surgeries? There's a few different ways that we can do this. Your surgery can be classified as body system. So body system can be useful for determining the risk of your postoperative infection. And we talked about this a little bit when we were talking about wounds and our contamination types of wounds. And we know that when we're cutting into things like our GI area, we're going to have a higher risk for infection, or we're going to have a higher risk for infection if we know that an organ ruptured prior to surgery, or if an organ was accidentally nicked during surgery. The next thing that we could classify by is the purpose. So was this a diagnostic or an exploratory surgery? So this would be done to confirm or rule out a diagnosis. So a biopsy, a fine needle aspiration, a cardiac catheterization, all of those are types of exploratory or diagnostic surgeries. We can also do palliative surgery. A palliative surgery is not going to treat or fix the underlying disease, but it should help to promote comfort for the patient. Then we could have the degree of urgency. So if we're talking about an emergency surgery requires transportation to the operating suite as soon as possible to preserve the patient's life or function. Right now, American Heart and Joint Commission usually want like a door to balloon time if your patient's coming in with like a STEMI, acute heart attack. They want door to balloon time in 90 minutes. So that means the patient has to come into the hospital, be identified as having an acute MI, get onto the cardiac catheterization table, prepped, and that balloon has to be across the lesion within 90 minutes. So that's a very rapid time. Then we have our urgent surgeries. So an urgent surgery is scheduled within 24 to 48 hours to alleviate symptoms. So that could be somebody who needs a fracture that's broken, or sometimes if they note a bad gallbladder, that might be a 24 to 48 hour. And then an elective surgery also falls under the degree of urgency. An elective would be, it's not an emergency, it's not urgent. If it doesn't happen, it's okay. But these are going to be something that's a recommended course of action. Something like a sinus surgery could be considered an elective surgery. And then the next one we have would be our degree of risk. So there's two degrees of risk. There's major and then there's minor. So your major surgeries are going to be something that is a high degree of risk. There's a potential for significant blood loss. Involvement of vital organs is happening. It's going to be a very prolonged or complicated procedure, or they could have a significant potential for postoperative complications. If it's a minor surgery, it's usually performed on an outpatient basis and involves little risk, and it usually has few complications. So a breast biopsy, maybe a hernia repair. And then as technology is advancing, certain things that were once major surgeries are becoming more minor surgeries. So I think about like appendices and gallbladders, and some of those used to be like complete open, where they would have to cut across your entire abdomen to open you up. And now they're doing them laparoscopic, and what was once several days in the hospital is now a same-day procedure. So as our technology advances, things that are major have actually progressed to minor, but we still like to know, what the surgery is. And if it's a minor surgery that has a potential to be a major, that needs to be discussed with the patient when they're doing their consents. So, for example, again, going back to the gallbladder, you can have a doctor who says, my plan is to have this be a minor surgery, but if I develop complications, it will turn into a major surgery. So we're going to start laparoscopic with 5 little holes. And if something goes bad, I'm going to have to cut you open more invasively. So some surgeries can be minors with the potential for major. So then we can fall into the purposes of the surgical procedure. So why are we having this done? And some of this information overlaps from what we just discussed. So is this a diagnostic? Are we doing this to figure out what's going on? So are we doing a biopsy so we know what type of cancer it is? Are we doing an exploratory abdominal surgery to find what part of maybe the intestine is not functioning correctly? Then we have where we actually ablative, and this is when we're going to remove a part of the body that's diseased. So if you have like a gangrenous toe, then we can have constructive, right? And this is going to restore function that's been lost or reduced. And for constructive, that would be a cleft lip or a palate repair. Reconstructive or restorative means that we're going to restore function or appearance to a traumatized or malnourished area. So a skin graft for a burn victim, or reconstructive surgery after cancer. Transplantation happens when we have a dysfunctional body part. So if you have a heart transplant, kidney transplant. Palliative, again, palliative is not going to fix anything, but it's going to improve comfort. So back surgery to decrease pressure in the spine would be palliative. And then we can have cosmetic, and cosmetics just going to improve a person's appearance. So liposuction or rhinoplasty. So next we're moving to the factors affecting our surgical risk. So all surgical procedures are going to have some degree of risk to it. People in good health have a lower risk. However, certain health conditions increase the surgical risk. Complications can be infection, delayed wound healing, or anesthesia reaction. So when we talk about mental and cognitive status, there are disorders that affect our cognitive functioning, such as schizophrenia, dementia, developmental delays, mental retardation, and all of this will kind of compromise a person's ability to interpret and understand medical information. These disorders can increase the surgical risk and interfere with the patient's ability to follow instructions and care for the surgical wounds. Some individuals may be prescribed medications that also could interact with their anesthetic medications, such as antipsychotics and anticonvulsants. So we would need to screen for that to be aware. And then nutrition. So malnutrition and obesity increase our surgical risk. We know that nutrients are necessary to promote wound healing and resist infection. Protein and vitamin K deficiencies will contribute to poor wound healing, respiratory depression, sedation, and clotting disorders. A protein deficiency interferes with a drug's ability to bind with proteins. As a result, plasma concentration of drugs can remain elevated, increasing the risk of side effects and adverse effects of medications given. And then we also have vitamin K deficiencies that can lead to increased bleeding. The use of illicit drugs and nicotine have a higher risk of adverse drug reactions. Certain drugs change the way anesthetics work during surgery. Drugs that are commonly abused, like cocaine, marijuana, alcohol, and opioids. When these drugs are taken, a potentially dangerous situation can develop for a patient. Wound healing is compromised in patients that smoke because smoking causes vasoconstriction, resulting in decreased blood flow. Smoking contributes to decreased ciliary action in your tracheal tree, and mucus secretions may increase. The tracheal tree may become chronically irritated, and anesthesia can actually increase this irritation. Before surgery is an excellent time to teach your smoker about the risks of smoking. Smoking puts a person at a greater risk for a reactive airway disease, which can contribute to constant complications such as a laryngospasm. A laryngospasm will cause the laryngeal muscle to suddenly contract, blocking airflow. Typically, this can last for a minute, during which the patient's going to have trouble speaking and breathing. If intubation is required during this period, it's going to be extremely difficult. And we want to encourage patients to stop smoking 6 weeks before they have surgery if we can. If patients are unable to cease smoking weeks before surgery, abstaining 24 to 48 hours will still have a very positive impact. Our familial history, so malignant hypothermia, this is a rare hereditary and life-threatening condition that usually occurs when inhaled general anesthetics or neuromuscular blocking agents are administered. Susceptibility to this is a autosomal dominant disorder, which you'll learn about more when you get into Med-Surg 3. But the important thing is to realize that malignant hypothermia causes severe muscle contractions and a rapid elevation of the body temperature. During an acute episode, the patient can develop a very high fever. We're talking like 105 here. Cyanosis, muscle rigidity, hypertension, tachycardia, tachypnea, hyperkalemia, so that's that high potassium, dysrhythmias, and acidosis. This change in the body temperature, chemistry, and temperatures can be life-threatening and can result in death without proper treatment. Even with treatment, a patient who has this can easily succumb and die. The signs of this disorder must be recognized extremely early for prompt medical treatment. And surgery should be stopped, and anesthesia needs to be discontinued if we feel that this is actually happening. And when we treat this, there's a special medication that they administer to help treat it. You should know that. Diversity considerations. So our lifespan, older adults and children have a greater risk associated with surgery. Infants have an immature sympathetic nervous system, which can increase the risk of bradycardia during surgery. Infants have lower blood volumes, so any blood loss can contribute to a rapid hypovolemic issue. They also do not have shivering reflexes as well, which can cause them to lose body heat and become hypothermic. Our older adults have many chronic comorbidities that can put them at a higher risk. So there's a potential for skin tears, pressure ulcers, COPD exacerbations, fluid and electrolyte imbalances, and many more issues, which we'll talk about in a few minutes. When we talk about our culture, ethnicity, and religion, just kind of think back to that last unit that we just did. Remember that some patients do not believe in surgery. Some groups, like our Jehovah's Witnesses, do not believe in blood transfusions. Depending on what their cultural influences, beliefs, and practices are, can influence how a patient will respond to surgery and to pain. It can be both positive or negatively impact on them. Our disability, any disorder that causes extreme anxiety will hinder the ability to understand and cope with the stress of surgery. And then our morphology, we know that obesity can cause significant mechanical difficulties for the surgeon. It can lead to excessive blood loss and problems exposing, accessing, and retracting tissue of the surgical site. During the post-operative phase, the obese patient can have difficulty with lung expansion, which can contribute to the development of pneumonia and wound infections. The increased depth and size of the surgical wound may cause wound infections and poor wound healings. People who are obese have higher risk of hypertension and cardiovascular, respiratory, and gastrointestinal complications, as well as delays in metabolizing medications. Hypoxemia is often associated with obesity due to increased respiratory effort, ventilation perfusion mismatch, closure of small airways, and reduced total lung capacity. So going more into the general health and medical history of our patients, all patients who are scheduled to have surgery have a careful review of their current health status. When a person is in a poor state of health, a surgeon may require a surgery to become delayed or canceled. When a patient's risk for infection is high, antibiotics are given prophylactically to allow medication to reach therapeutic levels in the tissue before surgery. So when we talk about cardiovascular disease, our cardiovascular disease risks increase during surgery. Disorders such as a myocardial infarction, which would be an MI, dysrhythmias, chest pain, hypertension, and heart failure need to be managed and controlled before surgery. A recent MI, chest pain, and dysrhythmias all increase the risk of a second MI and life-threatening dysrhythmias. When a patient has hypertension, the scheduled dose of an antihypertension medication may be given before surgery. If hypertension is not controlled, the risk of anesthesia and surgical complications significantly increases. In some cases, diuretics are withheld if the patient does not have a Foley catheter inserted or fluid loss is expected during the surgery. Heart failure may cause surgery to be delayed due to the risk of additional fluid and electrolyte imbalances. In contrast, sometimes our antihypertensive medications are held because we are at risk for them dropping their blood pressure during surgery. So it's really important to clarify those things with the surgeon and the anesthesiologist. Our blood coagulation disorders, so we can have bleeding, hemorrhage, blood clots, and shock can be caused by coagulation disorders, which can significantly increase our surgical risk. Laboratory results for our prothrombin, our thrombin, platelets, red blood cells, hemoglobin, and hematocrit are monitored to help identify potential risks. Respiratory disorders. A thorough assessment of the respiratory system is completed before surgery. Some anesthetics cause respiratory depression, predisposing the patient to a greater surgical risk. Respiratory disorders such as chronic obstructive pulmonary disease and pneumonia can increase the risk of respiratory depression during surgery. Renal disorders. Our renal disorders contribute to fluid and electrolyte imbalances, which can increase the risk of surgery. People with acute or chronic renal failure may not be good surgical candidates. They can have additional risks of blood pressure abnormalities, acid-base imbalances, fluid instability, and metabolism that is not able to be excrete their drugs properly. So what that's basically saying is you can give them sedatives, their body's not going to be able to metabolize them, so they might have a longer sedation period. And then we have our liver disease. So your liver disease interferes with the metabolism, protein synthesis, coagulation, and glucose homeostasis. So these manifestations of the liver disease can contribute to fluid and electrolyte imbalances, acid-base imbalances, and altered excretion and metabolism of the drugs, each of which can all increase the surgical risk. And then diabetes. Diabetes increases a risk of delayed wound healing. On the day of surgery, patients may not be able to have anything by mouth, so there'll be MPO. Glucose levels are going to be monitored closely, and insulin doses need to be adjusted accordingly. Oral hypoglycemic agents may be withheld. Glucose levels may fluctuate in a person with diabetes because of the stress of surgery, resulting in hypo or hyperglycemia. The stress of surgery often causes elevated glucose levels. This may result in patients temporarily receiving insulin through an IV site. And we know that IV insulin usually will help with more strict sugar control, and the less sugar, the better healing we have. So we also have medications that are going to interfere. And I talked about the antibiotics on the last slide. We'll get into that more in a little bit, but medications like certain herbs and alternative medications can increase the risk of cardiac dysrhythmias, secondary to loss of potassiums. They can interfere with metabolism and anesthetics because of their effects on the liver, and they can increase the potential for excessive bleeding, decrease cerebral blood flow, issues with hypertension. So it's really important that you know all herbal and alternative medications that your patient is taking. These are the drugs that your patient might be on that you need to know what they can potentially do. So antibiotics have the potential to potenate or make their anesthetic agents work stronger. Anticoagulants, of course, are going to increase our risk for bleeding. Antidiuretics can impair cardiac function during a procedure when combined with anesthesia. Our antihypertensives are going to increase our risk for hypotension during surgery. So we could have bradycardia or impaired circulation with those. Aspirin is going to increase our risk for bleeding. Corticosteroids are going to delay our wound healing and increase our risk for infections. Your corticosteroids are going to increase your patient's blood sugar. So when it increases the blood sugars, then we're going to have those healings and infections. Our diuretics are going to alter our fluid and electrolyte imbalances, especially our potassium. And potassium is really important to have normal when we're doing surgery. And then opioids. Opioids are going to increase the risk for respiratory depression. Non-steroidal anti-inflammatories are going to inhibit your platelet aggregation, which is going to increase the risk for bleeding. And then tranquilizers are going to increase the risk of respiratory suppression. So from here, we're going to kind of break it down into the three sections. And we're going to start with the pre-operative nursing responsibilities. So remember, our pre-operative phase starts as soon as the patient knows they're going to have surgery. So what's going to be important? It's going to be really important to get a nursing history. The nursing history is going to include your preoperative assessment of your health history, your mental status, your physical status, spiritual and cultural, coping strategies. When we move down to our physical assessment, you're going to want to identify risk factors from the nursing history. You're going to focus on those aspects during your head to toe. And the next slide is all of the optimal assessments that you need to do for an older adult. So if you notice that there's a barrier or a risk in one of these areas, this is where you would want to then start to think about what your planning would be to prevent an issue. So if your patient has a cognitive issue, right, they're not understanding the directions, they're not understanding the care, then we would want to focus on that. If they have a nutritional status and we know that they do not have good nutrition, we would want to try to promote better nutrition. If we see that the patient is very frail and we're concerned, we're going to have to figure out how to support that and get all of this as best as possible before they actually go in for surgery. So all of these are the areas that you would want to assess. You would also want to make sure that your patient has all the screening tests that they need to have. So depending on the patient's age, health history, and facility policies would kind of determine what they're getting. Most patients are going to end up with a complete blood count, a urinalysis, and possibly an electrocardiogram. Most institutions are okay with just a complete blood count and the urinalysis. And if the patient's older than 50, then they make them get the electrocardiogram. If they're over 50, they might need an electrocardiogram. And then if they have other cardiac history, they might need to have like an echocardiogram. Chest x-rays are not recommended for all patients before surgery. However, for the most part, if your patient's going to have general anesthesia and be admitted to the hospital, they're going to want a chest x-ray before they go in. And then you might also need to get a pregnancy test if your patient is of childbearing age and does not have a hysterectomy. Moving on to our surgical consent. So it is very important to know that the surgeon is the one who gets the consent. The nurse verifies or witnesses the consent. All consents need to be written in terms that the patient will understand. They all need to be done in the language that's spoken by the patient, and they all need to explain the risks and benefits of the surgery. Very often, most surgeons will just write that the risk is death, and the benefit would be restoring function. They don't get too technical with that stuff. For our preoperative teaching needs to begin at the beginning, and our teaching needs to include what the procedure is, what the post-procedural process is going to be, whether they're going to be home, whether they're going to be in a hospital, how they're going to handle their wound care. We want to teach them the turning, the deep breathing, the coughing, all of that prior to the procedure, because remember back to when we did our education, and I believe that was what, unit 1 or 2. When we're teaching people, we want to make sure that the patient has the optimal learning. So they need to be rested, they need to be able to focus. We want minimal distractions. So if we're trying to teach them turning, deep breathing, and coughing after surgery when they're already uncomfortable, that teaching is not going to be effective, right? So we want to do that beforehand. We can do preoperative teaching as a discussion. Sometimes they have group classes that patients can go to, and sometimes we're going to give them printed materials. So preparing our patients, we need to assess their status. When's the last time they had anything to eat or drink? Because we do not want them aspirating while they're on the table. So certain anesthesiologists have different requirements for when the patient last had carbohydrates versus when they last had protein, because protein is going to be in the stomach longer. When we move down to preparing the skin with a surgical scrub, we know that surgical site scrubs, they do betadine. That would be done more when they're actually getting prepped on the table, but as the Preoperative nurse, you might need to clip the patient. We no longer shave, we clip. And you might do like an HCG scrub on them before they go down. Our bowel preparation we did in lab. We talked about those cleansing enemas to empty the colon and get it ready. We also want to make sure that we can facilitate the patient urinating prior to going to surgery. Indwelling catheters are no longer a routine, but having the patient get up and urinate prior to going off the floor is good if they can do that. Any preoperative medications we need to make sure that we do. A lot of times they'll have an antibiotic on call to the OR. And that means that if the OR says we're coming up to get your patient, we want to go hang that antibiotic because it needs to be hung within an hour of their surgical incision. We want to make sure that we're assessing their vomiting status and things like that as well. And then we want to make sure that they have the anti-embolism stockings or the SCDs, something that's going to reduce the risk of developing a blood clot. So our additional preoperative nursing responsibilities, you're going to be starting a checklist. Your checklist should make sure that, you've done the proper, you've witnessed the consent, you've checked the lab work, you know when the patient was last MPO, the patient knows the site. Sometimes the preoperative nurse or the sending nurse will actually make an X on the extremity with the patient. You're going to need to give communication to the receiving surgical team. You're going to transfer the patient down to the OR. And once the patient goes into the operating room, now they're going to be in the care of the intraoperative nurse. So this is going to be inside the OR. And we usually have a sterile team. So the sterile team is going to include a surgeon, a surgical assistant, and a scrub person. Before beginning the surgery, they all perform a surgical scrub. And we know that the surgical scrub goes further up their arms. They're going to have the entire hairnet on, mask, gloves, gown, boots, all of that. A clean team are team members that just do medical asepsis. So this is going to be like the anesthesiologist that's in the room, maybe a circulating nurse, rad tech. These persons will not enter the sterile field, but they'll function around and beyond it. And then we have our anesthesia. So you can have an anesthesiologist, or you can have a certified registered nurse anesthetist. And then these people are going to be doing your anesthesia. So whether it's a moderate station, and we'll talk about the different types. And then again, we have our skin prep for our surgery. And then we have our positionings, which I have all these different positions for you to look at. And it's good to know what type of position your patient was placed in, because if they come back with a back pain or discomfort or shoulder pain, but you know that they had them in a lateral sideline position and their arm was stuck up for a while, well, then it's expected that their shoulder might be discomfort. So good information to know when you're getting a report. Now we're going to talk about our types of anesthesia, right? So we have general anesthesia. General anesthesia is going to produce a rapid unconsciousness and a loss of sensation. This is going to be an anesthesiologist or that nurse anesthetist. It's going to be inhaled or intravenous medications, and it's going to depress the patient's central nervous system and relax all of their musculature. Their muscles relax. Sometimes they give them paralyzing agents. There's going to be narcotics, inhaled gases. This is what's your general anesthesia. Then we have conscious sedation. So conscious sedation is sometimes noted as moderate sedation, or a patient might be told that it's twilight. This is going to be an intravenous sedation with a little bit of an analgesic, and it's going to not make your patient unconscious. but they're in a conscious sedative state. So they're going to feel sleepy. They're kind of going to be aware of their surroundings. They're going to be easily aroused by touch or speech. They can kind of talk, but they're going to have that amnesic effect where they're not going to be able to recall the procedure afterwards. This sedation is usually used for your upper endoscopies, sometimes a bronchoscopy, and a lot of it's used in the emergency room a lot when we're putting joints back in place. We also use it in interventional radiology when we're doing certain procedures. You do not necessarily need to have an anesthesia accreditation to give this. So that's why it's used in some of those other areas. And then we have our regional anesthesia. So this is going to be preventing pain by interrupting your nerve impulses to and from the area of the procedure. So the patient will remain completely alert, but is numbed in the involved area. A regional anesthesia may be administered by infiltration of the surgical site and the surrounding tissue with local anesthetics, such as a lidocaine or bupivacaine. These medications can be injected, and they're going to depress the sensory, motor, and sympathetic impulses of the limited area to the body. So kind of like your nerve blocks, sort of. And then we have our local anesthesia. So local is just going to be to that specific area. We can do like where we're just putting lidocaine in and we're just going to close a wound. We can also do a topical anesthetic, so like a lidocaine liquid, where we actually put that on the skin or the mucous membrane, and that kind of absorbs in rapidly. And then when we infiltrate the lidocaine into the skin with the needle, it doesn't hurt as bad. So intraoperative care to keep our patients safe. We want to do timeouts. Timeouts, depending on the facility you work at, can be extremely elaborate, but they all basically have to say that this is the right patient, this is the right procedure, and this is the right location of the procedure. So, you know, if you're doing a knee replacement, we're doing a right knee, we're on the right side. Then we can have our sterile field, you know, and you don't necessarily always have the ability to have somebody who monitors the sterile field. But if you are assigned to that position, you need to be mindful if anybody broke sterile field. You want to make sure that you're monitoring their input and their outtake, and making sure that they're not losing too much or getting too much. Sponge, sharps, and instrument counts. A lot of hospitals will have the person who is in charge of all of that will do the count, and they put the count up on like a dry erase board or somewhere where they know that I've dropped 22 sponges, 5 sharps, I have this amount of instruments down, and all of that's up. If the doctor needs more sponges dropped during surgery, somebody has to add those dropped sponges to the overall count. And then when the procedure is done, somebody sits there and goes through and says, okay, we started with 50 sponges, I have 50 sponges. We started with 25 sharps, I have 25 sharps. And it's very important to know that they're the same from the start of the case to the end of the case. And then documentation, right? We need to record the care provided, the client's response to the care on the surgical records. Usually they'll use like grafting for their vital signs, as well as for their input and outtake. If you have an anesthesiologist who's working on this patient, whether it's a nurse anesthetist or a general anesthesiologist, they'll typically be responsible for your vital signs and your INO, as well as your patient's response. And then the nurse would be responsible for additional things, like if the doctor used a balloon and blew it up to a certain pressure, some of that stuff the nurse might be required to chart that. So now we're moving into our postoperative phase, right? And some hospitals say that the case ends on anesthesia's time. Some hospitals will say that the case ends when the dressing is on. So when the patient stops bleeding and surgical hemostasis has been maintained, that's when the procedure ends. So, that would be more facility dependent. But once they move out to the post anesthesia care unit, this is when they're going to be recovering from their anesthesia. So we have to make sure that we maintain their airway. And we want to monitor their vital signs. We want to assess the dressing, make sure that they're not having any hemorrhaging, and we want to make sure that their pain is adequately controlled. This nurse is going to be responsible for doing an initial assessment on how they receive the patient. We're going to have to do frequent vital signs. We'll get to that a little bit more specifically later. Dressing management. Usually surgeons do not like anybody to remove that initial dressing. So they'll tell you to reinforce the dressing. Pain control. You need to continue with that DVT prophylaxis. Teaching the patient, again, well, you should be reinforcing really the incentive spirometer, the deep breathing and the coughing, early ambulation if possible, and then continuing our education with our patients. So our surgical care improvement projects, this is the SCIP. This is a Joint Commission checklist. So your patient, if they're on a beta blocker, they need to maintain their beta blocker. They need to receive their antibiotic 1 hour prior to their surgical incision. They need to have or any prophylactic antibiotics discontinued within 24 hours after surgery. We need to have their blood sugar controls. We need to have any clips, pins, or devices removed. If your patient's having a colorectal surgery, we need to make sure that they have normal thermia, the thrombus issues, and all of this again is set measures by the Joint Commission that get audited. And if the hospital doesn't have these met, it can lead to poor outcomes for their patients and poor outcomes by the Joint Commission, which we don't want. So this is an example of a surgery checklist. So in this particular checklist, you're looking over your patient's blood sugar, that you removed any hair or clips, that you've removed any wedding bands, what their diet was beforehand, what their last stool was, if they had their HCG bath the night prior, the morning of surgery. This goes under these medications. All of these are high-risk medications. So the date that they had it, the last time they had it, some blood levels. So this is just one type of surgical checklist. And then this is another surgical checklist, which is even more in depth. And this surgical checklist goes into, is your consent complete? Do they have their ID bracelet on? And their glasses in place, or the contacts, dentures, hearing aids? Because if they go into the OR with dentures in place and they need to be emergently intubated, they're going to take those dentures out. And we don't want to lose those. Or different types of antibiotics. If you gave an antibiotic, what time did you give your antibiotic? What's the patient's height, weight, temperature, respirations, pulse, perfusion? Do they smoke or do they not smoke? What's their skin assessment? Like all of this, if you notice, is your pre-op. This is all to get them ready so that they can actually go into the OR. And then there's also the latex screening. So with our latex screening, we're going to ask all these different types of questions that will say, are you at risk or not at risk? And the big section here is, have you ever reacted to any of the following? Latex. And you need to say, like, have you ever had a reaction to glues, to adhesive tapes, latex cuffs, dental masks, loft grips, rubber gloves, ace bandage, like everything. You have to ask each one of these items. This can be very time consuming. But it's important to know, obviously, because we don't want them to have a suspected latex reaction and go into anaphylaxis when on the surgery table. So now we're going to go into our nursing process. And this is our nursing process for your preoperative, intra and post. So when we start, our assessment, everybody gets the same, we want to make sure that they're safe. We want to make sure that we have our checklist done, that we do our focused histories, our focused assessments, and we take care of our discharge concerns, right? Because we know discharge starts at admission. So just like this, our discharge needs to start in the beginning. And all patients are going to be having concepts of anxiety, fear, airway clearance. The key point here is we need to identify risks and potentials so that we can reduce those risks and improve our patients' possible outcomes. Anxiety is very common when we're going to be having surgeries. Patients can have restlessness, trembling, increased pulse, and other defining characteristics of that. Fear is also very common related to surgery. Fear can be because they're unsure of the surgery or the outcomes of the surgery. We can have issues with our airways. So if they have pre-existing health problems like emphysema or COPD, we can have concerns for that. Risk for latex, knowledge deficits, infection, all of those things. For our special risk for older adults, again, going back to our any heart disease or concerns that they could have worsening effects while they're on the table, delirium, which gets worse because of the stress of surgery compounded with the medications that they're going to be getting during surgery. Again, with the respiratory, age-related skin changes, we know that the skin's frail, it's dry, it's thin. They're going to be put into positions on a table that could make them have an increased risk for a pressure ulcer, skin breakdown, skin tears. So all of these things can be special risks for older adults. Planning, we want to make sure that the overall goal of the preoperative phase is to prepare the patient adequately for surgery and to deliver them to the operating suite in the best condition possible. Outcomes that provide evidence of achieving this goal are those that are appropriately from nearly all patients. We want to make sure that we have their informed consent. We want to make sure that they understand what's going on. We want to make sure that they have very little anxiety. Our interventions, we're going to want to make sure that we coordinate care. When we are coordinating our care, this can be coordinating with physical therapy for aftercare, home care. Again, you want everything ready to go. You might need respiratory therapy there. Your surgical preparations, and again, going back, you want to teach them everything before they start. So now we move into our intraoperative assessments, right? So with the intraoperative assessments, again, you want to make sure that that consent is signed and that it's already witnessed, because once they get into the intraoperative room and you perform your timeout to make sure it's your right patient, your right site, and your right location, the anesthesiologist is going to start giving the medication, and then nobody's going to be able to sign that consent if they have anesthesia on board. So really need to make sure that the consent's done. You also want to make sure that that preoperative checklist is complete. And you want to verify everything on that preoperative checklist is not just complete, but accurate. You want to assess the patient's anxiety level and their physical condition when they come into the OR suite. We want to make sure that we know what their baseline vital signs are so that we know what we're going to be trending and expecting. We want to make sure that when we're transferring the patient from the stretcher or the bed onto the OR table, that we don't pull any IV sites, any drains, and catheters. We want to give them or ensure that they have the appropriate preoperative medications. and that they were given in holding. So if the goal is that they have to have an antibiotic 1 hour before surgery, has it been 1 hour or has it been longer, or did they not get it? We need to know this. For concepts for this patient's going to be in the OR, so we can have complications related to surgery, complications related to anesthesia. So are they becoming hypothermic because it's cold in the OR and they don't have enough warm blankets on? Are they having excessive fluid loss? Are they having musculoskeletal injuries secondary to the way that we have them positioned? Are we concerned about aspiration? Are we concerned about respiratory depression? Are we concerned about cardiovascular issues? We can have different types of concepts or diagnoses related to all the potential risks that can occur based on whatever procedure they're having. So your big goals when we're planning is we want the patient to be free from injury. We want them to remain physiologically stable, and we want them to have optimal surgical outcomes, right? More specific goals, we want them to maintain a normal body temperature, so normal thermia. Want to make sure that their lung sounds are clear, that their airway is patent, that they're having at least 30 cc's an hour of urine output, that they'll have no issues with their skin tissue or neuromuscular injury relating to the positioning that we're putting them in, and that they will not acquire a health-related infection. So no surgical site infections will occur, because of poor intraoperative care. Your interventions are going to be dependent on what you planned. So if your intervention is to make sure, if your plan is that your patient is going to have a normal body temperature, then your intervention is going to be, I'm going to make sure that I have plenty of warm blankets on top of them. I'm going to try to make sure that they get warm fluids and not freezing cold IV fluids. If you're concerned that you don't want them to have any skin or tissue or injury related to positioning, then you're going to position them really well. And you're going to make sure that they have good padding, and you're going to make sure that none of their bony prominences are being pushed onto that hard metal operative table. And if you're concerned about, that healthcare related infections, then, you're going to want to revisit your safety measures and make sure that everybody's maintaining sterile technique and not breaking sterile fields. So assessments for your post-operative care. So we've moved out of the OR. Now we're actually in that PACU area. And in this, your patient is going to be recovering from anesthesia and recovering from their surgery. So you're going to have your initial assessment, and then you're going to have your continuing assessment. So is my patient maintaining their airway? Is their level of conscious improving as the medication's wearing off? How's their vital signs? How's their intake and output? What's their dressing look like? What's their drains look like? How's their mobility? And then more with the vital signs. Typically, they have to do vital signs every 15 minutes for the first hour. Then it's every 30 minutes for the next 2 hours. And then it's every 4 hours, every hour for the next 4 hours, and then every 4 hours. And depending on how this is written, this might be as soon as they arrive on the unit, this is what you're going to do. Or it could be this has to be done in the PACU. And if PACU only did the first hour's worth of vital signs, then you, the nurse, have to continue to complete that while they're on the floor. So our different types of diagnoses and concepts at this point would be either risk for or potential for your tissue perfusion issues, fluid volume issues, breathing patterns, infection, or actual, like your patient is actually in pain or your patient actually has an activity intolerance. We want to make sure that when we're doing this, that we address anything that has a higher risk. So we do not want them to develop it from it being a risk to an actual, right? And your patient I believe in class I kind of touched upon here how, before a patient can be discharged, a lot of times they need to have a bowel movement. Before a patient gets discharged, they need to urinate because of the anesthesia can affect both the bowels as well as the urine retention. So you just need to be aware of those. Planning and our interventions, we need to keep in mind that we want our patient to be able to do their activities. They're not going to have pain. We need to make sure that pain control is individualized to each patient. We need to make sure that we do an interprofessional team approach. So we should formulate a plan for our pain relief. So that way, prior to the patient maybe going for rehab, the pain medication is already on board so that the patient can have an physical therapy regimen. What else do we want to say here? Again, with the urinary elimination, nausea and vomiting, we don't want somebody who's post-operative having nausea and vomiting, especially if they're still under sedation, because this can increase their risk for aspiration. This is a visual of the anti-embolism stockings. These are the sequential compression devices, SCDs. These help to promote blood flow and reduce the potential of your patient having a deep vein thrombosis. This is your incentive spirometer. So your incentive spirometer is going to reduce the atelectasis. Atelectasis occurs when your patient is under anesthesia, and it's kind of this little alveoli collapse. The patient is going to suck in on this device, and as they're breathing in, they typically inhale for about 3 to 5 seconds. Then they exhale slowly. They'll repeat this 5 to 12 times, and they'll perform the exercise every 1 to 2 hours. Gastrointestinal suction. So commonly when our patients have GI surgeries, they can develop a paralytic ileus, which is basically that the bowel is not paralyzed. So your patient can then have a obstruction from this. And if they have an obstruction, they're still going to continue to make their gastric secretions. And because the gastric secretions cannot move past this paralytic ileus, they're going to then come up through their mouth, and they're going to vomit them. And if they're vomiting them while they're under sedation, they're most likely going to aspirate, and then they'll get aspiration pneumonia. And that is a hospital-acquired issue, and we don't want them to have that. So we put in a nasogastric tube, and we decompress their stomach, and we remove those gastric secretions. These need to be hooked up to intermittent suction, and we'll be playing with them a little bit more when we get into lab. Our big thing that we need to remember with these is we need to make sure that we're wearing sterile non-sterile gloves when we're emptying the drainage. We need to make sure that we have a lubricant to their lips so that their lips do not get dry, because if they have this, they're not going to be having anything to eat or drink. And we also need to make sure that we document the consistency and the amount of the drainage that we're getting out. When we talk about our deep breathe, cough, move in bed, and perform leg exercises, all of this is what we need to do with our patients. This education needs to be done prior to the patient going to the OR, but it's going to need to be reinforced when they come out of the OR. So we're going to need to educate them on the difference between coughing, truly coughing, and just kind of giving a little clearing their throat. The idea is to cough, because when we cough, we're going to open up that airway, and we're going to get any secretions that might kind of pull there to come up. We want to make sure that they know how to splint when they're moving in bed. They can flex their knees before turning to help move from side to side easier. When we're using a pillow for support, we just need to make sure that they have the pillow is not like flat, but it's actually going to provide them with support. The same thing with whatever they're splinting with needs to have support to that. And then in your volume 2, it actually shows these different exercises that they can do in bed. These exercises will also help to reduce their chance of blood clots. So we have some additional complications that we can get from surgery. The number one would be our airway obstruction. So remember, we talked about the fact that smokers are at that increased risk for laryngospasms. And when we have a laryngospasms, we're not able to breathe. We can also get airway obstructions because our tongue can fall back into our pharynx, or we can have them from bronchospasms or aspiration of our gastric contents. So it's really important to make sure that we do not get an airway obstruction. And if we do, we got to take care of it. The next thing is hemorrhage. Hemorrhage would be a large amount of blood loss. It can be immediately after post-operative. We can have loss that we actually can see, but then we can also have internal loss that we cannot see. And we're just going to get the signs of hemorrhage, which would be that tachycardia, hypotension. Patient might get a little clammy, a little pale, a little diaphoretic. Usually when we're bleeding internally, we also have some discomfort associated with that. However, your patient's still sedated, they might not be able to vocalize that they're having discomfort. They might just be a little bit more restless than what they were beforehand. We can also have external blood loss from, a surgical site that's bleeding. So whenever we see blood on a dressing and we want to reinforce it, make sure that you wear gloves, because a small little dot on the outside of the pad might grow very much when you press on it to put a new pad on top of it. The thrombophlebitis. So this is when we have the blood clot in the vein. The vein's going to be kind of inflamed. The patient will have like pain at the area of it. And then they can also have a deep vein thrombosis, which would be your DVT. And this can result during the trauma of the surgery. So how they have them positioned on the table, if it impedes their flow of their blood, or other things can happen. But patients with that are going to have cramping in the legs, pain, redness. They can have swelling of the extremity as well. We can get pulmonary embolisms. So pulmonary embolisms are going to be a blood clot that lodges in that pulmonary artery. It can be very painful. And the patient will complain of chest pain, shortness of breath, they'll kind of have a cough. If it's really bad, they might have some cyanosis, dysrhythmias, tachypneas, tachycardias. Typically, if a patient is post-operative and they developed a PE, they're most likely going to need to go to the ICU for care of that. We can develop a pneumonia. So really, atelectasis kind of come first. So with atelectasis, we have the collapse of the lung tissue, and those little alveoli are gonna kind of not allow that gas exchange. And then with too much atelectasis, then we can develop into pneumonia. Usually 48 hours to 72 hours post-operatively. Your patient can also develop pneumonia if they end up aspirating during or after the procedure. They don't necessarily have to aspirate stomach contents. Sometimes they can have excessive pulmonary secretions that they can aspirate and have this happen. If your patient has pneumonia, they're going to have shortness of breath. They're going to have adventitious breath sounds. They can have fevers, chills, and they're going to have a cough. They may also have purulent or rust-colored secretions from that cough. And then we also know that we can develop wound complications, right? And we've talked about that, where the dehiscence is when it pops open and the viscerations is when the contents spill out. We know that this can be 48 to 72 hours afterwards, and that if this happens, we need to apply that sterile gauze with the moist sterile saline on it, and we need to contact the surgeon because that's a medical emergency. Some additional post-operative care that we're going to have to do, again, early ambulation. We need to have the patient call for assistance when they get out of bed. If the patient feels weak or dizzy the first time they ambulate after surgery, that's common. So we want to make sure that they dangle before attempting to stand up and ambulate. We might want to have an extra person with us the first time that we walk this patient, just to make sure that they do not have any issues. And if they do, there's 2 of us versus 1 of us. Early ambulation will help prevent the complications of constipation, deep vein thrombosis, atelectasis, pneumonia, and even urinary stasis. Also, if they're having gas pains, this can help with that as well. Our fluids and hydrations, we want to make sure that we maintain fluid volume. IV fluids are infused at a specific rate, and then we need to make sure that we're monitoring those INO values. We want to assess our IV site. We want to make sure that we have the right solution, and we know that adequate fluid intake will help keep the stool soft, and it'll help keep the lung secretions thin, and it'll also help prevent urinary complications or kidney complications, especially if your patient had died during the procedure. Our diet advancements, so we know that your patient was NPO prior to going surgery. We need to make sure that the gag reflex returns. A lot of surgeries, they'll put in like acetylcholine in the back of the throat. We don't want the patient eating if they do not have a gag response. They might start the patient off with just ice chips, and then they'll advance as tolerated. We need to make sure that we assess the bowels for bowel sounds. They need to have flatulence, and their bowel does not need to be distended. Some patients can start with a clear diet and advance to a regular diet very rapidly. And then discharge, remember the postoperative nurse is going to be potentially doing the discharge, especially if it was an outpatient procedure. Discharge instructions need to include medications, wound care, activity, diet. If we're discharging them to home, we have to have some home considerations. So, if they have a family, they need to know as well what the patient's allowed to do, what they're not allowed to do, so that they don't expect them to do things that are not in their activity approval. We should also know about dressing changes, signs and symptoms of when to seek immediate medical attention, any risk for complications. Next, we have our wound assessment checklist. And again, this goes back to our wound assessments that we just did. So we need to know what's the size, and we know that the size should start to decrease with healing. What types of closure is it? How are the edges? Are they well approximated? Are we stapled closed, suture closed, steri strips, or just surgical glue? If it's surgical glue, you need to tell your patient that that's going to fall off on its own. That's not something that they need to pick at. That's not something you as the nurse needs to pick at. Some surgeons are wonderful with their surgical glue. Others gets really sloppy. And some people try to pick at it to make it look neater, and instead they dislodge it, and then the patient has issues. We need to know our drains. So what type of drain is it? What's it putting out? Is it putting out what it's supposed to? What's the consistency of it, the color, the amount, the odor? And then, of course, monitoring for signs of infection. So is there any redness around the skin? Is there any purulent drainage? Is there any foul smelling drainage? These are Montgomery straps. So Montgomery straps are good for patients that have excessive drainage or will need frequent dressing changes. tape can become very irritating to the skin. So we can do this and it will help hold that drainage sponge down without having to tape around it. And that is the end of our perioperative lecture.